So I will give you a brief overview, and then we need to hear from the true experts who deal with much more rheumatic heart disease than I do personally. But I have had an interest in this field for a number of years from the epidemiologic point of view. We have many publications, reasonable data but not complete data. World Health Organization report from 2004 regarding rheumatic fever, rheumatic heart disease, the Global Burden of Disease report. Although it's dated 2004, it was actually published in 2008, addressing the epidemiology issues. We do know in the developed countries, such as where I live, that rheumatic heart disease is declining substantially. And you'll note that it declined well in advance of the antibiotic era. It declined because of sanitation, nutrition, and public health. But in the rest of the world, this remains a big problem. And the papers by Jonathan Karpaitis and others clearly point out the issues of where rheumatic heart disease remains big threats. Africa, South Asia, Southeast Asia, Aboriginal populations in Australia. We'll hear shortly from Egypt and Yemen. Africa in particular, you can see the sub-Saharan continent, greater than 5.7 cases per 1,000 people, and in some countries up to 14%. We'll hear it from Susie recently, has data suggesting even higher prevalence in Aswan. The burden is clear. The existing cases is an estimate of 15 million people, 300,000 new cases per year, nearly 300,000 deaths per year, and this is probably a minimum because of the underdiagnosis of this condition in many of the developing countries of the world. Why is this the case? There are two factors. First, the socioeconomic and environmental factors related to poverty, undernutrition, overcrowding. This comes from the WHO report 2001, leading to a rapid spread of the streptococcal strains in a situation where there is difficulty in accessing healthcare, leading to an impact of higher incidence of acute pharyngitis and its suppurative complications, therefore a higher incidence of acute rheumatic fever, and the implications in the healthcare resources required. The second feature are the health system related factors: shortage of resources, inadequate expertise of providers, and low level awareness of the disease in the community, so that the patients or the parents of the patients are not coming to attention early enough. Therefore, there's an inadequate diagnosis and treatment of the initial strep infection, leading to a higher incidence of acute rheumatic fever and its recurrence. A misdiagnosis or late diagnosis of acute rheumatic fever, such that patients are unaware of the first episode, do not become candidates for secondary prevention, more severe evolution of disease, untimely initiation or lack of secondary prevention as a result. And finally, inadequate secondary prophylaxis or non-compliance with secondary prophylaxis, leading to higher rates of reoccurrence, leading to what we see as true rheumatic valvular heart disease. This has important implications from not only the health of a country, but also the economics of a country. This is looking at one metric of community, country economics related to health, years lost due to disability. And one sees in Southeast Asia, South Asia, and Sub-Saharan Africa that rheumatic heart disease has an economic impact equivalent to malaria in Asia, almost equivalent to HIV/AIDS and tuberculosis in Africa. And so this is an infectious disease which is somehow not grouped according to infectious diseases when we talk with the individuals who are funding for programs to reduce infections in developing countries. Somehow rheumatic fever and rheumatic heart disease is not part of the equation. Is primary prevention of rheumatic fever the missing link in developed countries? This paper by Karthikeyan and co-workers looked at the impact of primary prevention programs in two small countries, with relatively captive populations, treating the first infections of pharyngitis with antibiotics and demonstrating a very significant drop in rheumatic fever prevalence per 100,000 individuals over the course of time. Now, one could argue that these data may be incomplete, there may be underdiagnosis and so forth in these two nations, but does suggest that in a small captive population, primary prevention may be useful, but in larger rural situations that we deal with in most developing countries, this may or may not be practical for the reasons outlined earlier. And this is where secondary prevention becomes quite important. A number of papers have pointed out that the clinical diagnosis of patients who have rheumatic heart disease, therefore candidates for secondary prevention, is an underdiagnosis, and that echocardiography screening may be much more valuable. Here's a study from Marjan co-workers, nearly 6,000 children in Cambodia and Mozambique. The cases of rheumatic heart disease diagnosed clinically and by echocardiography, clearly demonstrating a much higher detection rate with echo, leading to calculations regarding the prevalence of rheumatic heart disease per 1,000 in the population, where the echo to clinical ratio is 10 to 13 times higher with a more accurate diagnosis by echo. Furthermore, the same co-workers then did some further calculations based upon the diagnosis of rheumatic heart disease based upon WHO criteria versus a combined clinical WHO and echocardiographic criteria, demonstrating that with this combined criteria using ultrasound, one has a substantially higher detection rate, higher prevalence, both in girls and boys, all age groups. And when they then calculated what this would mean for a particular city, they found that there's a 4 to 5-fold increase in the detection rate using echocardiography. So echo clearly is available in most developing countries. There's a colleague of Dr. Yaqub and mine in Ethiopia, who is a well-trained echocardiographer, has led to a multinational program in Africa. Here is Mayosi pointing out that the Pan-African Society of Cardiology convened a workforce in 2005, leading to a program called ASAP, that's Awareness, Surveillance, Advocacy, and Prevention, trying to galvanize the resources available for both greater community awareness as well as greater echocardiographic surveillance. The World Heart Federation has also taken this on as well, with some demonstration projects in several countries in Africa, as you can see, Egypt, Ethiopia, Ghana, South Africa, and other countries as well. And therefore, there are growing data from various countries in the developing sectors of the world, from India, Africa, and other countries, demonstrating the portable echocardiograms can be used to have a much better surveillance mechanism for initiating secondary prevention. We'll talk later, I think, with the next speakers about the compliance with secondary prevention and how well this actually works once detection is undertaken. The World Heart Federation has listed the elimination of rheumatic fever and the minimizing the burden of rheumatic heart disease as one of its 5 key points of the strategic plan, along with other issues of global cardiovascular health. The World Heart Federation just a few months ago published a consensus document regarding how to define the diagnostic criteria for echo surveillance for detection of underlying rheumatic heart disease, for identifying individuals for secondary prevention. Definite RHD, depending upon pathological MR and morphologic features. MS of any kind usually is indicative in these countries of rheumatic heart disease. Pathologic AR with morphologic features, or a combination of mitral and aortic valve disease. And then also borderline conditions which probably in most communities would prompt strong initiatives for secondary prevention. And they also illustrated the morphologic features one would anticipate in patients who have rheumatic MR or rheumatic MS. Finally, surgery is an important component of a program to eradicate the end stages of the disease. And so training the next generation of cardiac surgeons in developing countries is also a key initiative. Certainly Dr. Yacoub has taken this on as a mission in his life as well. Now, where we run into problems with this is looking at rheumatic heart disease in developing countries against the other ravages of cardiovascular disease that is occurring worldwide in developing countries. So we know that worldwide, 30% of all deaths, that's 17 million people per year, are cardiovascular in origin, that 80% of the cardiovascular deaths occur in low and middle income countries, not the developed countries, not the high income countries. But where is the emphasis on rheumatic disease in these low and middle income countries? If we go to the Global Atlas on Cardiovascular Disease Prevention and Control, a combined report from the World Health Organization and the World Heart Federation, 164 pages worth of data regarding the epidemiology and the impact of cardiovascular disease worldwide. Here is what we find, that against the spectrum of all of the things that lead to mortality related to cardiovascular disease, rheumatic heart disease accounts for only 1% globally, for both men and women. And when one does the economic analysis regarding the impact in terms of quality of life years lost, this is now 3% for men and 4% for women related to rheumatic heart disease. And this document of 164 pages has one page detailing the issues related to rheumatic heart disease, and it's probably aptly named the chapter, A Neglected Heart Disease of the Poor. Poverty, children need to be protected, and it is somewhat neglected. In fact, that's also the topic of the letter to the editor that followed this paper in Science regarding some neglected diseases being more neglected than others. And among these neglected diseases, rheumatic heart disease was not mentioned by the author, and therefore this prompted a letter to the editor that rheumatic fever is neglected again, even in a paper addressing neglected diseases. Rheumatic heart disease was neglected, and therefore pointing out that this is a condition which is preventable, either as a primary or secondary initiative. It requires public health initiatives, it requires global awareness and community awareness as well. And therefore, when one moves into the current era of the focus now on non-communicable diseases at the level of the Institute of Medicine, the UN report on non-communicable diseases, it's quite possible that rheumatic heart disease will be lost in the shuffle over these larger epidemics that are occurring worldwide. But in the developing countries, in the poorer countries of the world, this clearly remains a major public health threat, and something that I think we all need to be aware of and using our advocacy efforts to try to address more fully. Thank you very much for your attention.